Okay, so my presentation today is on rickets. So just a quick definition. The rickets is a condition of deficient mineralisation at the growth plate leading to architectural disturbances, whereas osteomalacia, which Annabelle will be talking about later, is a condition of deficient mineralisation of the entire bone matrix. So as you can imagine, both tend to occur at once, but once the growth plate is fused, then only osteomalacia can occur. So rickets only affects children. The etiology. So initially I thought it was just about vitamin D deficiency, but it is a lot more complicated than that. So you can have calcipenic rickets or phosphopenic rickets, depending on which is the primary deficiency. So calcipenic rickets is, as you can imagine, caused by deficiency in calcium, but the most common cause of that is issues with vitamin D. So that can be low sun exposure, having dark pigmented skin, dietary deficiency, so for maternal deficiency leading to the child having a deficiency through breastfeeding or during pregnancy, and then disorders of vitamin D metabolism, so inherited enzyme deficiencies and other conditions. And you can also have reduced absorption of vitamin D or calcium, such as cystic fibrosis, pancreatic conditions, gastrectomies. And then you can have dietary calcium deficiencies, but that's a less common cause. And then phosphopenic rickets tends to be caused by inherited conditions where you have the renal phosphate wasting, so tubular acidosis, Fanconi syndrome, X-linked conditions, autosomal dominant, autosomal recessive conditions. You can also, again, have dietary phosphate deficiency, but that is also rare. So before going to the pathophysiology, I just thought I'd go through some quick definitions so we're all on the same page. So when talking about strength of a bone, that is the amount of force required to cause a fracture. Stiffness is the resistance to elastic deformation. Toughness is the amount of energy an object can absorb before breaking. And ductility is the total amount of deformation an object undergoes before fracturing. So that will come up a bit in the pathophys. So pathophysiology, calcium and phosphate deficiency can lead to impaired mineralisation. At the epiphysis, impaired mineralisation leads to cartilaginous overgrowth. This leads to chondrocytes losing their orientation, leading to persistent, disordered, irregular masses of cartilage at the growth plate. And this, in turn, results in impaired bone growth and deformities. And additionally, there'll be a lack of mineralisation throughout the whole bone matrix, which will increase the ductility of the bone because we know the mineralisation is what gives it that strength, leading to further bone deformity. And although we have an increase in ductility, their global reduction in mineralisation throughout the bone reduces the extrinsic stiffness, which can predispose to fracture. And I quite like the graph on the left-hand side. So you can see a normal bone can take a certain amount of load and then it will deform a small amount and then it will fracture. Whereas in rickets, we have the increased ductility. So at smaller loads, there's increased deformation, but will also fracture under a lower load than a normal healthy bone. So then clinical features, you can think that there's an increased risk of fracture, there'll be pain and there's deformities, but what specific deformities? So there'll be delayed closure of the fontanelle, parietal and frontal bossing, craniotapes, which are soft skull bones, this rachitic rosary, which is an enlargement of the costochondral junction along the anterior lateral aspect of the chest, the Harrison sulcus at the lower margin of the thorax due to pulling of the diaphragm on the softened ribs, so they can't resist that force as well anymore. And then bowing of the distal radius and ulna and widening of the wrists, and then what we're all familiar with would be bowing of the femur and tibia. But we also need to consider that the bony deformities are determined by the age of the child and the stage of development, because that will influence what bones are experiencing what weight-bearing forces and which directions. So infants tend to have forearm bowing and distal tibial bowing because they are crawling, whereas toddlers, which are beginning to walk, tend to have genivarus deformities, and then older children will have valgus deformities. So how we diagnose rickets. So if we suspect rickets, you can do alkaline phosphatase activities, and then you'll do some plain radiographs. You also want to measure the parathyroid hormone level, phosphate level, and calcium level to determine what's driving the rickets. So if the parathyroid hormone is high, we can imagine that's because our calcium is low. And then if phosphate's normal or low, then we can see it's more of a calcipenic rickets. Whereas our normal parathyroid hormone and normal calcium levels with low phosphate indicate a phosphopenic rickets. But if all of these are normal, we need to consider there's probably a different cause to the bone deformity, and that needs to be investigated further. Widening of the metaphysis and cupping just through here compared to along here. And then we have our classic bow leg deformity, and then this is the rachitic rosary. I think it's better seen here where you have enlargement of the anterior costochondral junctions. So treatment, if it's a dietary deficiency, you want to do high dose vitamin D. So in children for 1 month to 12 months, that's 3,000 international units orally daily for 3 months, and 5,000 units if they're over 12 months old for 3 months, and then you taper down to 400 international units for a long-term supplementation as needed, unless their risk factors change. So a child that's got a lack of sun exposure, hopefully you just get them out in the sun more, but if it's because of skin pigmentation or other conditions, they'll need lifelong supplementation. Similar with calcium supplementation, 1,000 to 5,000 milligrams daily, and you want to educate them on how they can get more calcium and vitamin D in their diet. But inherited conditions, you really need to refer to specialists, usually endocrinologists. Complications, so most cases will improve with treatment, but it can take a number of months, and even cases of severe bow legs will improve without surgery. But severe cases might require surgery, but this is quite rare, and you only consider this after medical optimization. However, growth retardation may be permanent due to irreparable damage to the integrity of the epiphysis. So surgical therapy, there's 2 main procedures. You can do a tibial osteotomy, and that corrects the angular deformities of the knee. So you unload the knee by correcting tibial malalignment, and that's done by taking a wedge or dome from the tibia to correct the alignment, and the bone will then heal around that. And then you also have the hemiepiphysiodesis, which is guided growth, where you temporarily arrest bone growth on one side of the physis, usually on the longer end of the bony deformity, and then bone growth will now only occur on the shorter end, correcting out and straightening the leg, and then when it's at the level you want, you can remove that temporary arrest. You can also do permanent ablation of certain sides of the physis. And that is everything.